Well, nowadays in the current practice, IMiDs are being used for frontline and for relapse patients. And for the IMiDs which are used for frontline, it's mostly lenalidomide. And so most of the patients now who are on long-term lenalidomide who acquire resistance, there is a need to make a decision on which type of treatment should be chosen for them. So the next option is either to switch the class of agent or to move from one IMiD to another one. And so per se, lenalidomide versus pomalidomide. So there was a discussion earlier, patients who are progressing on lenalidomide, are they going to be sensitive to pomalidomide? Earlier studies which were for relapse setting, they included patients who were exposed to lenalidomide and proteasome inhibitors, but not refractory because of the design of the studies. But nowadays, newer studies are focusing on patients who are exposed and also refractory to lenalidomide. And one of these, and the first of this example, is the Optimism study, which has been published 3 days ago online in Lancet Oncology, and we had the privilege of being a part of that study. And the study proves to show that the combination of pomalidomide with bortezomib dexamethasone is better than bortezomib dexamethasone in terms of response and PFS. And the hazard ratio is about 0.5, which is a very good, highly good number. And there are ongoing studies which are combining pomalidomide with monoclonal antibodies. And one of them is going to be an oral presentation at ASCO very soon. And others are in the pipeline. We are also participating in those studies. And so the message for today is patients who are refractory to lenalidomide, they can be given a pomalidomide combination either with a proteasome inhibitor or hopefully with a monoclonal antibody. So the algorithm for treatment design is going to change based on the fact that frontline lenalidomide is being used more commonly. So we have to design second line and third line therapies based on the exposure and resistance of the patients.